Hello, everyone. This is Kathy Bush, and welcome to the DandleLION medical webinar titled Grief in the NICU. Our faculty presenter today is Taryn Schuelke. Taryn certified in thanatology, death, dying, and bereavement through the Association for Death Education and Counseling. She is currently a practicing grief and bereavement specialist on the palliative care team at Texas Children's Hospital. Prior to this role, she worked as a certified child life specialist in the NICU and Women's Services Department at Texas Children's. She has spent many years supporting grieving families with the many losses that occur within the healthcare setting. She is trained in providing dignity therapy for dying patients, which is a life review form of legacy building. Taryn has a BS in Human Development and Family Sciences through the University of Texas at Austin. And to further her education in the death and dying field, she is currently pursuing a Master of Science in Thanatology through Marian University in Wisconsin. Welcome, Taryn. We are so happy to have you.
Thank you so much, Kathy. I'm really happy to be here, and thank you for everyone who is interested in this topic and knows the importance of caring for people who are grieving, specifically in the NICU setting. I loved my time working in the NICU. It was a dream job for me, honestly. And during that time, I truly discovered the absolute honor and sacred work of working with families who are grieving, and specifically families who are grieving the loss of their baby. And working with families during that time showed me that this is actually what I wanted to pursue for my career. It's not very common that you hear of someone who's a grief and bereavement specialist, though there are several of us out there. But when our palliative care service opened at Texas Children's, this opportunity presented itself, and I knew that if I didn't take it, I wouldn't be able to do the sacred work that is so rewarding for me, for every child across the lifespan and any kind of disease progression or illness or injury. And this is truly a topic that's near and dear to my heart. So I'm very thankful to be able to present it to you all today. Just a couple housekeeping things. I wanted to let you know ahead of time that I have 3 slides worth of references at the end of my presentation. So all of the information I'm providing you today, I've done a lot of lit review, a lot throughout my career, and I'm kind of a reference junkie. So I hoped to do that to equip you with some tools and just some, light/important reading if you care to look at the literature around death and dying in the hospital setting and bereavement after death. I've also included a paraphrased glossary at the end. So I'm going to go over several terms in this presentation, and I just wanted to alleviate you of the pressure of taking quick notes or writing things down quickly about different types of losses and grief. And I went ahead and paraphrased everything at the end with a good resource for you to do a little bit more reading yourself and a little bit more education. So before I get started, I just wanted to make sure that you all are aware of that. And I have a lot of content, and I want to make sure that there's plenty of time for questions at the end. So I'm just going to dive right in. I have no disclosures. I'm affiliated with Texas Children's Hospital, but this is not associated with the hospital, and I have absolutely no disclosures to provide. And you have previously seen the learning objectives, which I'm assuming is why you're here right now, but I want to go over them briefly just to get our minds in this setting of grief in the NICU. So by the end of this, my hope is that you will be able to describe at least 2 types of grief and loss. There is a general term called grief or bereavement or mourning, but what I hope to teach you today is some tools about different types of grief that you will be able to keep in your back pocket to utilize in your practice. So I hope they will be easy to remember for you. And with that, it's all about applying it, right? So I'm going to be sharing a few communication techniques that have been helpful both in my experience and also helpful, were said to be helpful by families that I've read in the literature as well. So communication techniques, some new habits to form, some really good stuff. And then the last one is I'm going to share some ways that we can support grieving families in the NICU. There are a million ways, and my hope really is to inspire you to get creative in how you support your grieving families at your NICU, wherever you are providing care to neonates. So I'm going to give you a few ideas, but my true goal is to inspire you to think for yourself at your institution, what can I do to make this better for families? And we have to start with a little bit of a foundation. So whenever people typically think of grief, they think of sadness, pain, suffering, death, and sometimes people will think of, the 5 stages of grief. Okay, so we're going to address all of that, but I want to give you a very solid foundation about loss and grief, because there are a lot of misconceptions out there about what is a loss and what isn't, and what is grief and what isn't, and how do I help people? What do I say? What can I do? So before we can do any of the application, we have to have a solid foundation of knowledge. So in order to do that, I'm actually going to take you through a timeline, a NICU admission timeline, to illustrate all of the different types of losses and types of grief that families experience when their baby's admitted to the NICU. So we're going to start with actually the pregnancy test, because this is where it all begins, right? So a family discovers they are pregnant, and there are a lot of emotions mixed up in that moment. I'm hoping you'll be able to get into this mindset with me. So you have a positive pregnancy test. You're either super thrilled or you're super terrified. Either way, maybe it's a mix of both. There is anticipation that begins. A life is coming. A life is now invaded your space. So anticipation begins. And then at whatever point this occurs, let's say it's an ultrasound or that first NIPT blood test, you get some bad news. Things are not normal. You're a little worried and something came back not right. In that very moment is your first loss. It's a loss of security. I'm no longer safe. This can happen to me. It doesn't just happen to other people. It happens to me. And I don't feel safe anymore because this kind of devastating thing can happen. And so that is really a first loss, is this loss of security. And then you progress through the pregnancy and you're preparing for this delivery. And then the delivery is probably not going to go the way you planned it. I mean, that's true for anyone, but specifically for families who have prenatal diagnoses or families who have birth injuries. So all of a sudden, their ideal birth experience, their ideal experience of what it would be like, those first moments with their baby, is shattered. It's gone. Their baby is whisked away to a NICU. So they lose this ideal experience that they've maybe always hoped for, and that's gone. They don't get that back. There's no coming back from that. So there's a loss of an ideal. And then you're admitted to the NICU, and nothing is normal anymore. You are now in a sterile environment, harsh lights. You might not be able to touch your baby. You certainly probably won't be able to feed your baby. All of these normal experiences, and your normal is completely gone. You have to adapt to this new environment, to these new emotions, this new sense of loss of security, loss of an ideal experience. And now you've lost everything that's normal to you. And then if you have to go through a prolonged NICU admission, there are so many other losses that come along with that. A lot of families that I've worked with have shared that they've lost friendships. People didn't show up the way they hoped they would. People didn't understand or validate their experience, and so they lost friendships. Some people have lost their jobs. They have to be at the bedside a lot, and they have to miss a lot of work, and they end up just having to quit or they get fired. People lose their jobs. You certainly lose your sense of control. And by a long NICU admission, you know that you have no control anymore over anything. And that's a loss. You lose a lot of rest, even more than normal, even more than the typical delivery, birth, new family experience. You lose rest because you have all of these emotions and worries piled on top of already not sleeping very well and recovering and being at your baby's bedside. You can lose confidence in a lot of things, confidence in yourself, in yourself trying to become a parent. And what does that mean? Am I a good one or not? You can lose confidence in your medical team. Unfortunately, I'm just going to be real this entire presentation. Families lose confidence and trust in healthcare professionals. It's just reality. And there are a lot of reasons why this happens, but it certainly happens. And it's devastating for families because they trust and they want you to take care of their baby and fix their baby and make their baby better. And there are some things that make families lose confidence. And hope, specifically hope. What we've learned about grief and loss is that hope is one thing that it stays, it remains, it persists. People continue to hope. You'll hear that word thrown around all day long in a NICU. We're not giving up hope. We haven't lost hope. We're still hopeful. Those kind of things happen all the time. But the fact that someone is having to say those things means that they're feeling an attack on their hope. And that's a loss, is that they're feeling their hope is at risk. And some people do lose hope. Some people lose hope. So there's all of these losses. And just as a side note, while the family is experiencing all of these things, here we are over here, medical staff, having family meetings, after family meetings, after family meetings, after family meetings, presenting them with information, having them make decisions, bringing all specialties together and sitting down in a room. And it's a big ordeal. There are all of these things happening on the healthcare professional side. But on the other side of that is a family who is grieving many, many losses. And so it's not a wonder why we experience so many families who we feel like just don't get it, or they're not listening, or, I said that already and they didn't hear it, or I've shared that information already. They know it. It's not a wonder why they're making decisions that might be contrary to what we would make a decision for. They're grieving. They've experienced a lot of losses. So I just want you to keep that in mind as we move forward into the practical things. And then something might happen that no one wants, which is the death of that baby. In the United States, at least half, if not over half, of all deaths occur by the age of 1. So this happens a lot in the NICU. Death is something that you are just going to have to deal with and learn how to help and learn how to support if you work in a NICU. But for the family, this brings on not only the loss of their baby, but even more losses of an identity. Am I still a mom? Am I still a dad? Who am I? Why did God make this happen? Or why did God let this happen? I've lost my faith. I'm questioning my faith. This didn't happen for a reason. What's the reason here? And some people even lose purpose. I've spent my entire last 10 months or 2 years preparing for this baby, and now they're gone. What do? I don't even know what I am or who I am or what I'm supposed to be doing anymore. So there's the worst loss, which is the death of the baby. And then it's compiled with these other losses. And then life goes on for them. It has to. It does. And even as they continue living, these families can experience more losses. Unfortunately, literature and statistics and research show that families who experience the death of a child, it's very likely that their marriage will suffer or end. And specifically in the NICU, postpartum depression is a real thing that we need to be concerned about. So a lot of these families have depression, PTSD, and they might lose their will to live. So there are a ton of losses, as you can see, just throughout this whole timeline. And so what I want to do for you is give a name, help you be educated on what these things are called. So I'm going to give you some terms, and we're going to talk about losses first, different types of losses. There are many, but I've picked a few that I think are really applicable to the NICU. So all of these losses down at the bottom half of your screen are secondary losses. A secondary loss is a loss that occurs because of a primary loss. So all of these losses have occurred because it was a pregnancy that wasn't normal or a NICU admission. And all of these losses happen on the side, or if it is because of the death, that's a secondary loss. There are many, many secondary losses, and many I haven't even listed here. An ambiguous loss is an interesting topic. It's an interesting term. It's really a type of loss that makes you kind of wonder, I feel sad, I feel pain, I feel grieving, but what is causing it? I don't really know. It feels ambiguous. It's kind of existential and can feel strange to some people and feels like they're not validated. And so all of these secondary losses can be ambiguous losses as well. And so it's helpful for us as healthcare providers to know what these losses are and know that they are true losses in order to help identify that for families. So all of these are non-death losses. And then we have a death loss. So there's two different types. There's an actual death, and then there's all of the rest that goes along with it or before it. And because of that, there are different types of grief, if that makes sense. So all of this secondary loss and ambiguous loss brings on some specific types of grief that we see all the time in the NICU. So the first one is cumulative. Cumulative grief is when you have loss after loss after loss, which you can see here, and it all piles up on itself, and you have a really hard time discerning, I'm feeling this way, where is it coming from, which loss is it from, I'm not sure, but it's just a big hunk of loss, and I can't really distinguish what it is from that. Masked grief is pretty interesting. So it's the physical and emotional experiences caused by a loss, but the person doesn't recognize them as related to a loss. So, for example, they might feel really angry at their nurse, or they might lash out at the washing machine because it's not working. And so they feel angry. So they might think, okay, I'm just, I'm out of control. My hormones are out of control, or I'm just stressed, or I've lost sleep. But what it could actually be is grief. It could be related to grief. So it's really important for us to know that all of these behaviors and experiences could actually be related to grief. It's just a different lens. All of this is like you're putting on a pair of goggles and seeing people in a different way. It's another tool. Disenfranchised grief happens a lot with early infant loss, even prenatal loss, especially prenatal loss. Disenfranchised grief is grief that is not acknowledged by your culture or your close family and friend units. So the people who would be supporting you don't recognize your loss as a true loss. And so your grief is disenfranchised. It's that feeling of no one gets me, no one understands me, this isn't valid. This isn't a real loss, so I shouldn't be grieving. It's all of that should language. But it is grief and it is a loss. So they feel disenfranchised by people that matter. And then there's this very specific type of grief called anticipatory grief, which is the period of time leading up to the baby's death. So the family and the team are anticipating a death. It seems inevitable. And there's this anticipatory grief of a death. They're anticipating an actual death. There are a lot of different kind of emotional experiences that go along with that, and a lot of kind of logistical planning questions and experiences that happen in that time period of grief. So all of that kind of goes with these secondary and ambiguous losses. But when a death occurs, there's even more types of grief. And I've picked a few out, just a few, that might help you with your framework as you support families. So after a death, a family can experience delayed grief, which typically happens when a person pushes their emotions down. So they are specifically choosing not to grieve and choosing not to feel. And so here's the thing. You can't do that for long, or you can try, and it will cause you a lot of health issues and mental health issues. but it will come out. So it's called delayed grief, when grief comes up much later than is quote unquote typical. Complicated grief. Infant death is very complicated. I've had some families tell me, I didn't even want this pregnancy in the beginning. I didn't even want this baby. I didn't want to be a mom. And then I got pregnant and I was resentful and I wished that I wasn't. And then my baby was born and I loved my baby. And now my baby's gone and I don't know how to feel because I didn't want them in the first place, but now I do want them. And there's just so much complication that can go along with infant death. And traumatic grief as well. So some of these NICU families, these babies are there from hypoxic ischemic events at birth. So it's a traumatic delivery and then a traumatic NICU experience. And when these families, so a traumatic grief is in response to a death that went suboptimally. It's very subjective, but suboptimally for what the family would have hoped for their child, or an actual traumatic death, like witnessing prolonged CPR or intubation or, all of that experience. It might feel kind of in a way normal to us because we've seen it before. It is not. It is not for those parents. It is traumatic for them. So there might be some PTSD that they're worrying about in the future. And then last but not least is absent grief. We've all had those families where you expect to see the, quote, typical grief reactions leading up to and at the time of death. And it's just not there. They're not emotional. They're carrying on as things are fine. Their baby died. They're holding their deceased infant. And there's no typical grief responses in those moments. And so you see that, and a lot of judgment happens. Unfortunately, just being honest, a lot of judgment happens whenever a parent reacts that way. But it is a type of grief. It's absent. Everyone grieves differently. Everyone grieves differently. So just because it's not being displayed doesn't mean they're not grieving. So absent grief doesn't mean that there's not grief. It just means that you don't see it. It means that it's very internal and they cope with it in a very specific way. So yeah, those are a whole bunch of terms for you to have. Again, there's a glossary at the end. I hope that was helpful just to present you with a framework of different types of grief and different types of loss. I say all this, and you might look at this slide and say, okay, this is category 1, category 2, and we're going to put families in this box and that box. What I want to be clear about is there is no wrong way to grieve. All of it is grief. All of it is loss. All of it can be acknowledged and validated and supported. There is no wrong way to grieve. So some of these maybe have a negative connotation, these terms, but the purpose of knowing what these things are is so that you are equipped as a healthcare provider when you see something or hear something that your family is saying to identify that in your mind and then switch your brain on and say, oh, got to put my grief glasses on and care for them and their grief with some of the tools we're going to talk about in a minute. So how can we be helpful? That is the question. We hear all this, we see it, and sometimes we feel completely at a loss. We don't know what to do or how to help. And this sentence is your first communication technique. We in palliative care use this sentence all the time with families in consults. How can I be helpful to you? How can we be helpful? And if you give them time to answer, they'll probably come up with something, or at least they know that you want to be helpful. So that's your first tip, is use this sentence. I think it's really important to take these terms and have a foundation of terms, but what's also really important is to have an idea of how grief works. What is it like? How can I frame this in my mind to kind of help identify with families what they're experiencing? So there are a lot of grief theories out there, a lot. I've chosen 3 that are my favorite. That sounds really nerdy, but it's true. These are amazing grief theories that I think are so practical and simple and absolutely accurate to use as a framework when helping families. But first, I want to talk about staged grief because, like I said, when you ask anyone, hey, what do you know about grief? Someone will probably come back at you with, oh, yeah, the 5 stages of grief, Kubler-Ross. If they know anything about grief, that's probably the first thing they'll say. I'm here to set the record straight. Grief cannot be staged, okay? If there's one takeaway from this entire presentation, I hope it's this. Please change your own mental framework and know that we cannot stage grief. And this is why. Elizabeth Kubler-Ross was an absolutely incredible person. She did amazing things. She helped so many people as they were dying, and she's helped so many grieving families move forward in their grief. So back when she was alive, she died, I think, around 2005. Back when she was alive, she did some research in the 50s and 60s, which today would not be considered research just for her methods, but back then it was her research. And she would ask many dying people about their experiences and what it was like to experience the dying process and to come to terms with the fact that they were dying. And so she wrote this book on death and dying in 1969 is when it was published. And in this book, she delineated the 5 stages of death and dying. Please note that I did not say of grief and grieving. The 5 stages are only about people's experience of dying, adults' experience of dying. So therefore, know that it's completely irrelevant to what we're talking about today. It has nothing to do with grief. It was never intended to be applied to grief. It was only intended to be used as a framework for healthcare professionals for caring for people who were dying and were aware of their dying process. So, grief in the NICU, staging grief, it's irrelevant. It doesn't apply. And it's interesting to me that our culture has just tagged on to this staged grief situation. However, it's not surprising. We in American culture, at least where I'm from, avoid pain and suffering at all costs. We do our very best to make it end. All of it. We want it to be over. So it is not surprising that our culture latched on to staged grief because it's a stepwise process that has an ending. But here's what I want to tell you right now. Grief does not end. Grief does not ever end. Why? Because grief lives where love lived first. That is not my quote, but it is absolutely true. Grief lives where love lived first. And because love did not die and love does not die, grief does not end. We learn how to move forward with it and adapt to our life with it, but it doesn't end, unfortunately. So because of this, it can actually be really harmful for people who have this framework while they're grieving, like, okay, I need to be on step 1, step 2, step 3, step 4, step 5, and I'll be done. In fact, there was a mom that I was working with. I was doing some bereavement follow-up support, and she had this framework in her mind. She said that she's a very type A person. She likes to be organized. She likes a plan. And she thought that there was a staged process in grief, because that's what she'd always heard. And she was so frustrated that she was not getting to acceptance. She could not understand why she was not moving forward on the stages. She got to see a psychologist who luckily had some really great foundation of grief theory in their training, and they set their record straight for her. But for her, she felt like because she wasn't moving forward in stages, that she was doing grief wrong, that she was not good at it. And that caused a completely different variation of her grief process. And so it was a relief to her to know that she was normal and it's okay. It's okay to not have to move through stages. So I'll get off my soapbox there and start talking to you about some actual helpful grief theories. And I chose 3 because I feel like they apply really well to the NICU. The first one is the assumptive worlds theory. And this is a great term to keep in your back pocket, assumptive world. So this can apply to all those secondary and ambiguous losses, and even death loss, but specifically to the non-death type of losses. So let me explain this real quick. An assumptive world, we all live in our own assumptive world, okay? And Janoff Bullman really delineated the three things that we feel like makes the world a livable place where I can live and be somewhat happy. And that is the belief that the world is good, the world has meaning, and that I am worthy. In order to have any shred of happiness in our life, we have to cope enough to feel like some element of the world is good and there is some meaning and I am worthy. And that's what the assumptive worlds theory is. Well, here's the thing. Anytime an event happens where there's a loss, boom, your assumptive world is shattered. Well, that can't happen in a good world. This can't happen. My baby shouldn't be in the NICU. Babies shouldn't die. How could this be a good world if babies die in it? Or the world has meaning. There's no meaning in this. There's no meaning in my baby being sick in this isolate, having been born too early. Where's the meaning in that? There's no purpose in that. There's no meaning. Or I am worthy. What did I do to make this happen? Why did this happen to me? So those are the kind of things you'll hear in the NICU. You'll hear parents say those. And I want you to, when you hear those things, acknowledge that they are grieving the shattered assumptive world that they once held. There's hope. They can rebuild it. And we all do. That's called coping. But that is what this framework kind of looks like with this assumptive worlds theory. The second one is probably my favorite. It's called the dual process model of grief. So it's really intended to be for death losses, but I found that it actually applies to non-death losses as well. So the idea behind the dual process model is that people, when you grieve, you wax and wane. You know, you go from intense emotional, physical experience of grief, and then you kind of have a reprieve. And then you go back, and it's kind of like waves in the ocean. It ebbs and flows, right? So the dual process model reflects that. And the two types of grieving that it delineates are loss-oriented and restoration-oriented. So what this looks like in real life. When a family loses a baby, when a baby dies, some loss-oriented grief looks like intense sadness, crying, ruminating on their baby and what was and what might have been, grieving all of the experiences that their baby has gone through and wishing their baby was still with them. And it's a very intense emotional experience. The actual tangible side of that is, like a funeral, going to visit a graveside, standing by the cremains and, experiencing that loss experience again. And then restoration-oriented grief looks more of like, okay, what do I do now? Who am I now? What do I do with my baby's crib? What do I do with my baby's nursery? How do I restore my life around this loss? How do I move forward? So all of those things kind of ebb and flow. And what they noticed is that at the time of death, the loss-oriented type of grief is more acute. So it's more profound. There's some of both. And that over time, as people learn how to cope and restore, that the restoration-oriented grief takes precedent. There's still some loss-oriented grief there, but it changes and shifts and morphs over time. And the third one is real simple too. This one is specifically related to death loss. It's the continuing bonds theory, and they actually wrote an entire book on this phenomena. So the idea behind this is that when someone dies, their physical presence is gone, but their spiritual presence remains in your life. So there's a bond, a relationship. So you have a relationship with a person, their body is now gone, but their presence in your life still remains. And when I say spiritual and when they say spiritual, we don't mean religious. We mean that non-tangible part of who a person is, the spiritual side of things. So continuing bonds theory really promotes continuing that relationship and figuring out how to keep someone's spiritual presence alive in your life that's helpful to you and meaningful to you in a way that you feel connected to them still. So there are a lot of things we can do to promote that, actually. And a lot of families, you know, it's a very human experience. You know, you see a picture of your loved one that has died, and you think about that memory of that moment when you took that picture, and you relive that, and it affects you now in your present. So it's a very simple, practical thing, but there are ways we can actually promote that bond continuing on. And just a brief overview, because it's been a lot of information, I realize that. So here's a few facts. Grief cannot be staged. There is no time constraint to grief. There is no wrong way to grieve, but there are harmful ways to cope. And loss increases your morbidity and mortality. It's something that we have to be very aware of. And here's the kicker. Well, many people say stupid things. It's just the truth. We all, at least we think we care. And we all try to do our best and we try to care. But well-meaning people say stupid things. And there are so many things that people say that they think will be helpful that actually can be harmful to people who are grieving. Ask any person about a loss that they experienced and some really stupid things people have said. I guarantee you they will have at least one to offer you. But let's go ahead and apply all of that so that we can have some discussion at the end. All right, communication. All of this is about communication. So I just want to start with some blunders that I've witnessed and experienced in my career, and also that the literature says to be aware of. These are things we should avoid. We should avoid interrupting people when they're sharing their story, when they're talking about their grief or their loss. If we're talking as healthcare providers more than the family talks, we need to start thinking about why that is and figuring out how to change that. This isn't about us. It's about them. This is their experience. This is their family story. So the family should actually be talking more than we are. So that way we're able to hear more of where they're coming from and validate their own experience. We miss cues all the time in the healthcare setting. And by this, I mean we're talking to someone and a facial expression changes, or the tone of voice changes, or they back away, their physical body moves backward. There are specific cues that are missed all the time that can alert people to change the way they're talking or maybe stop talking. But we miss cues, and those are huge opportunities. Kitchen sinking, my favorite communication technique. Learned about this in college. So kitchen sinking, what that means is exactly what it sounds like. You know, imagine you're sitting at a family meeting and this specialty is talking about the brain and all of those updates. And then you've got the gut updates, and then you've got the lung updates, and then you've got the skin updates and the eye updates. And then you have, you know, all of these things kitchen sinked, everything but the kitchen sinks on the table. It's too much. It's too much for families that are grieving. There's only so much information you can hold in your mind. And sometimes we kitchen sink and then we're shocked about why families can't remember what we said. Appearing distracted or aloof. Please be as present as possible. It's a reality that we all have other patients. We all have other things to do. We have places to go, meetings to get to. But appearing distracted or aloof can be harmful to families when they see that. Checking your watch, checking your phone, taking a phone call. As best as we can, we have to try to avoid that blunder. Misalignment. We want to make sure we're aligned, at least in our communication with the families. We might not be aligned in our values, but we need to at least be aligned in how we're communicating, in our compassion with them. And lastly, making it about you. This is not about you. It's not about me. It's about them. It's their story. So staying away from our own experience as much as possible is really important. All right, so here's what we can do. I'm going to give you some specific things that you can say and say to families that we've used all the time and are really great little tidbits. So ask and be silent. silence is golden when you're talking to families. It's really awkward outside of the hospital setting, so we try to avoid silence at all costs, but in the hospital setting, it's really important. It allows them time to process and time to communicate back to you and share what they're thinking. So what has this been like for you? It gets their true experience without placing any kind of, negative or positive connotation to their NICU experience or, the death of their baby, what that was like. What has this been like for you? What are your worries? What are your hopes? How can I be helpful? These are very open-ended questions that they're not yes or no. If the family doesn't answer, it's shocking. These are questions that people usually answer with something. So it's really good communication starter. And then my favorite, what else? If you say what else with a family as they're talking, what that says to them is that you're not in a hurry, you're listening intently, and that you want to hear more from them. And that is so validating and compassionate to say in a conversation with anyone, but specifically in a time when people are grieving. And here are some ways that you can validate their experience without actually knowing if what they're experiencing is normal or like maladaptive coping. We can't all be experts in everything, right? But there are some sentences we can all say that still validate their experience. Like, a lot of families I've talked to feel blank or have said blank. And that just shows like, hey, you're not alone and other people have experienced this too. And it's super validating. This is a good one. I can see how much you love your baby when, and then say a specific thing. Or I can see how much you love your baby by you being here. And that validates that relationship. It promotes continuing bonds. It helps with feelings like guilt and anguish. Validating the love is really important. I can't imagine what this is like for you. It's so easy to say, I totally understand. You're so right. I get it. Don't say that. You don't understand. You don't get it. Even if you've experienced something that's pretty similar to what this person is experiencing, it's not you. It's not your baby. And it's just not true. You don't know what it's like. So we can't say that. And it's so hard, even for me. I'm speaking and telling you this, but even for me to say, I can't imagine what this is like for you, instead of, I totally get it. I understand. And I'm here for you. So simple, but so powerful. I would be remiss if I didn't mention culture. Communication and culture go hand in hand. They cannot be separated. So ask how people prefer to receive information. Again, we cannot all be experts on every single culture and everything, every way that people prefer to be spoken to. So asking someone how they like to receive information, or just their preferences on communicating, will set you up for success in the future when you have to have really hard conversations. And respect what their culture, what their religion has created in them. It's going to benefit them in the long run. So respecting what they need to do and how they need to act and be is so important, because they have to live on. They're going to leave the NICU and they have to live the rest of their life. And it's their culture that they're going to be living in. So we have to respect it. And we've got to leave judgment behind. These are not our kids. This is not our story. So we have our own values and the way we would want to do things. And that's so important to know for ourselves, but we can't judge other people by our own standards. So we have to leave the judgment behind. All right. There are a lot of supportive services and a lot of supportive things you can do for grieving families. First, spiritual and emotional support. It's hand in hand. Grief is not separated from spiritual and emotional support. So I love this. This is not my quote again. I don't know who said it, but I love it. Everyone is spiritual. Not everyone is religious. So call your chaplain. If you have a chaplain, consult your chaplain. They're non-denominational. They can handle spiritual distress and issues. There's spiritual pain and emotional pain in grief. So it's highly important that you consult your expert, your chaplain. And the roller coaster and the mixed bag. I've heard these two phrases used so many times in the NICU about emotions. It's a roller coaster. It's a mixed bag. Everything's jumbled up together. So consult your social worker. Your social worker is an expert in helping families start to weed through everything they're experiencing. And your child life specialist, especially when there are other kids in the family, because that's the majority of these families have other kids. Those kids are also grieving. And they're a lot of times the most disenfranchised grievers in the entire bunch because they're kids and, people don't really think about that. Child life specialists are experts in talking about grief with children and helping equip families and helping their kids cope. And of course, there are extremes. So my advice to you would be to consult these three frontline psychosocial supports. And then if they make their assessments and see, this is something beyond my scope, then yeah, let's get psychology or psychiatry involved. And we can really support our families in what they truly need to the depth and breadth that they need it. In a hospital, it is an interdisciplinary environment. And I don't mean multidisciplinary. I mean interdisciplinary. We have to communicate with each other. We've all got to be on the same page. I cannot tell you how many families, grieving families that I have spoken with that said, nobody was agreeing with each other at the end. Nobody had talked to each other. I had to say the story over and over again. I had to relive this over and over again. They said that it was supposed to be this medication, but they got that one. And there's a lot of breakdown of communication in healthcare. So it's really important that we have a united front, because that complicates grief whenever they feel like things didn't go according to plan with their whole team. And grief is multidimensional, so our care should be too. We all need to work together. One specific service, you all know I'm a palliative care professional, that I really want to talk about is palliative care and when to consult them and why and how. So there are two types you would see in the NICU, perinatal and pediatric palliative care. If your hospital has both, then they work hand in hand, and they will figure out who's the most appropriate to see that family. We offer a myriad of services. So most importantly, it's just an additional layer of support. Palliative care doesn't take over the primary care ever. We're a consulting service, so it's like an added layer of goodness on top of what goodness you are already doing. And thank goodness for concurrent care. For pediatrics, you're not on palliative care, that quote. So does this mean I'm on palliative care? No. You can pursue full court press curative treatment and care and have palliative care also. So it's kind of a beautiful thing in pediatrics that we're allowed to do this. And also, palliative care doesn't mean you're dying. It doesn't. It just means that you have a very complex situation with a life-limiting illness, and it doesn't mean you're acutely dying. It just means you need that additional layer of support. And they offer a lot of things like pain and symptom management. Our physicians are specifically trained on extremely distressing pain and symptoms, especially at the end of life. They are whizzes with meds and non-pharm ways of addressing these things. So really helpful. All the psychosocial support, they work with the primary team, and complex medical decision making. This is a lot for families to have to deal with. So it's good to have a full team to help facilitate what's important for the family and not what our goals are, but what are the family's goals. And I did want to touch for a moment on when a baby dies. There are some things we can do in that moment that will help promote positive coping and grief. A baby death can be traumatic or it can be peaceful. Are you going to allow that family to have alone time? Are you going to move that baby to a room where it's not so out in the open or close to other crying babies? There are very tangible, specific things we can do. We can help families who are avoidant become more involved by giving them preparation for what they're going to experience. The color change that their baby's going to experience when they die, what final breaths sound like, and that it's not distressing to their baby, it's only distressing to us, things like that. And then we ourselves can be harmful or supportive. We have a lot of power in these moments. So treating the family with respect and dignity and compassion and being supportive of whatever they're going through and whatever they need giving them as much time as they need, not making them feel rushed, doing things that promote their family involvement, getting them chairs and blankets and water and snacks. We have to feed and water these families that are grieving because they're not doing it themselves. There's so many specific practical things that you can implement in your hospital that will create a peaceful, involved, and supportive environment when a baby dies. One of those things is legacy building, and I want to touch on this very, very briefly. The Child Life Department at our hospital does a lot of really amazing memory making in the NICU, and I love this quote, "A person's a person no matter how small," and that's the heart behind legacy building in the NICU, validating that life, validating those little people that really made a difference and are true living people that want to be remembered. We make plaster molds here, ink prints, photography. There's some great organizations out there that do photography. You can get so creative with memory making. And this doesn't have to be and shouldn't just be at the end of life. All of these things can be done well ahead of time when they're tied with more positive memories. They become a linked object to that moment in time. So if we can do all of these things ahead of time and not have them be a death ritual per se, then the legacy building and memory making items will actually hold really nice memories as well. And families have said over and over, it's so important to have logistical support at the end of life. They don't know what to do. They've never done this before. So giving them resources, helping them plan, are they going to bury their baby? Are they going to cremate their baby? How do they want that to look? And a lot of this stuff actually can start in anticipatory grief, and families can kind of feel weird or guilty about that. But they might want to start planning for the death and the aftermath of the death even before their baby dies. And it's important that we validate that and we normalize that experience and support them in that. And then, of course, referrals to their community. What support groups are out there, what counselors are out there, things like that. Social workers are on top of all of this. And a little video here near the end, just for you to watch, that I thought was really illustrative of what we're talking about.
Why did this have to happen to me? Why wasn't I worthy to take my son home? All these things happening to my body, and I have nothing to show for it. I have no baby to show for it.
It affects everything. Socialising, working, just being is very difficult.
I remember thinking, how am I going to get over this?
As a man, you just feel like a bit of a failure because your missus is there crying and that, and you just feel like you're helpless.
We would always make sure we had Leo's memory box with us because it felt like that was him.
I took to my Instagram account. I found quite a few people that had lost babies. To find this group that can say what's in your head when you can't get the words out just makes you feel less alone.
I think the main thing is talking to your partner. Just be there for each other, do you know what I mean?
I had counselling, which I was offered before I left the hospital. I probably had about 10 or 12 sessions, and I think that really helped us.
It helped me understand her state of mind. We were able to help each other more, whereas had we not had it, we were poles apart.
So, finally, follow-up support is so important. I hope you could hear kind of in those families' voices, the importance of the grief process and how very complex and deep it is even now for them. And I will just say that there is some great evidence-based practice programming that hospitals have already put out. We have one here that provide a framework for following up with our families to make sure they're getting the support they need after the death of their baby. It's imperative. It needs to happen. Families feel abandoned when they leave here by their hospital. They feel abandoned. When they leave their hospital without their baby, they've lost that support of the medical team. So we have to follow up and bridge their experience back into their community. They want it to be personal. So if you knew them, that's more important. And it should be multidimensional. So, paper resources, phone calls, cards, all of that. And truly the key is compassion. If you have compassion in whatever you say and whatever you do, you're starting from the right place. So it's hard to work in a NICU. I've done it. It's tiring. There's a lot pulling at your attention. And it's just important to remember to wear compassion on whatever you do. Here's that glossary and 3 pages of reference for you. And I'll take about 5 minutes of questions or comments.
Taryn, wow, thank you so much for an absolutely brilliant and thorough webinar. It was amazing and chock full of information. We're so appreciative of your sharing. We will, as Taryn said, we'll open up for questions. We won't limit to 5 minutes, if that's okay with Taryn, because
Of course.
We have lots of questions coming in already.
Yes.
If you look at the bottom of your Zoom screen, run your cursor over the bottom, you'll see a Q&A box, and that's where you should look to type your questions. And Kathy Randall is with us, and she's going to help Taryn to get the questions answered.
Yeah, thank you so much, Taryn. That was amazing. I think one of the questions that came in really early was, and I think you maybe alluded to it right at the end, so I just want to confirm for the person who asked, was, how do you really distinguish between quote unquote normal grief and then that depression and anxiety that really needs attention?
Mm-hmm. Yeah, so that's a really difficult fine line because everyone is so different. Everyone grieves differently. They have different coping skills. There are different social determinants of health, you name it. It's variable for everyone. So I think the main thing that I would do is consult your social worker and have them do an assessment, a psychosocial assessment, to see, is this just normal grief? And there's a lot that goes into that. Or with a depression screen, PTSD screens, those exist because those are DSM diagnoses. Does this family need to escalate? Does this mom screen positive for postpartum depression, or does this dad screen positive for PTSD? And if they do, then please refer them and help them get help.
Love it. That's helpful, I think. I'm trying to read through these. You guys have so many great questions. They're asking maybe for an approach that you found successful for parents who react in anger.
That's my hardest one. Families who are angry, truthfully, to be vulnerable, the angry families really get to my heart and soul. And those are the ones I go home thinking about at night. So I've had to learn some personal skills and how to handle that, and to know that anger is a completely normal reaction to loss. It's completely normal and it should be expected. So I've reframed my mind to know this family is going to be angry about something, and I'm going to find it if I talk to them long enough and it's not personal. I cannot take it personally. So some of the language that I use when I hear anger, I'll give you a specific situation that I was in. So there was a family whose baby suffered a birth injury, and there was nothing else medically we could do for the baby. They were completely neurologically devastated. And we had a family meeting, and I was a child life specialist at the time, with everyone, and they shared that news. And this family was angry at baseline, the kind that are really stoic and kind of closed off and distrustful of the medical environment. So I knew this wasn't going to go well, but they were so angry at the news that they were given. They were so angry that it scared the medical team away. So the physicians and nurses actually stepped out to give them some alone time. I stayed. I'm not sure why I stayed, but I felt like I should. I didn't want them to feel like they were alone. So they started talking to me and asking me, the next steps questions. Just sat in silence. Silence is great, guys. Silence is great. I'm telling you. They started asking me the next steps questions. I presented one of our specific things that we offer to our families, which is a private room that they could be in for their baby to die. It's really beautiful. It has a crib. It's intended to not feel like a hospital room. And I presented it just like that. And I said, it's supposed to feel like a home. And the mom blew up. and yelled my head off saying, it is not a home. It is nothing like a home. This is not a home. Man. And so what I did is I just validated her in what she said. You're right. I'm sorry I said that. That wasn't the right thing to say. You're absolutely right. So saying and validating their anger. And then because I didn't clap back at them a little bit, they kind of softened a touch and were like, I'm sorry, but this is not okay. They kept going with it. And they're like, I'm sorry, but I'm going to yell. And that's just me. And all I did was say, you can yell. This is an awful situation. I give you permission. You're not going to scare me away. I'm still going to be here. Even if you yell at me. Now that's not for everyone. And it definitely takes some practice and skill to absorb anger. And like I said, I've had to work at it a lot, but if you can do it to enough that you feel you can handle, and then you're going to take care of yourself later. And I think that's kind of the best approach, is to validate and not be scared of their grief. Because you might be the only person in their whole life that isn't scared off by their anger.
Wow. That's an amazing answer, but also like, oh my gosh, how do you even learn that skill?
I'll never forget that family ever.
Wow. Wow, where do we go from there? My goodness. Let's see. What is a good time to have open communication with parents during the dying process, when the baby actually passes? Saying, I have had parents who don't want to chat at all with staff.
Yeah. Everyone's different again. But one thing that we like to do in palliative care, it's kind of a technique that we use, is we fire warning shots. So no matter what discipline you are, this is helpful. If you know that it's not looking great, if you know that there's something coming that might not be what everyone is hoping for, firing a warning shot is really helpful. So before things get bad, saying things like, I'm going to be honest with you in the way that you want me to be honest with you. I will tell you the truth. I'm going to be here for you. If we get some information that is not what you're hoping for, how do you want me to tell you? And I want you to know that I will honor and respect whatever your wishes are, but I will make sure you know beforehand so that you have time to take care of whatever you need to take care of. And that's the thing. Families want to know. They may not seem like it. They do, though. They really do. Unless they have blatantly said, do not talk to me about anything medical, which then at that point, you can't progress in medical care. That doesn't happen very often. The literature shows that families want to know. It's the healthcare providers that don't want to say it. So it's our own intrinsic fear and worry about saying hard things that are actually making these situations hard. So if we can start early enough being honest and open with the small things, and then we fire a warning shot of, hey, I have some difficult news that I need to share with you and talk to you about. When can I do that? What day are you going to be here? What time? Let's set up a time. And then that puts the ball in their court, and it doesn't blindside them. They're in control. Any element of control we can provide back to families is so important. So letting them dictate when and how that information is provided, it's going to set you up in a trusting relationship to have harder conversations at the time of death, more honest things. It's going to pave the way for all of those really important, difficult things to be said.
Wow, that was really good. I like this idea of the warning shot, and then also asking for preferences. I feel like those are some real tangible takeaway, practical things all of us can really try.
It works.
To
I
do.
promise.
Yeah, no, I can really see that too. I mean, because I just loved how you said all of that. So I hope everyone was taking frantic notes on this. Oh gosh, let's see. So someone's asking you to put on your child life hat for a second.
Okay.
And share some of your go-to verbiage for 4-year-olds. So siblings and younger siblings, So I guess 4 and younger and 4 and up. So what are your go-to resources, go-to wording for talking about baby's death?
This is a great question. Okay. So 4-year-olds, this is very specific. And I just want to throw this out here that every single developmental level in a child is different in how you want to address their grief. That's why child life is so important. So they can make their assessment on what developmental level, not even age, but development, that they are able to handle information. But I guess my go-to language and resources. Language would be, I really love Socratic method. I've done an entire presentation through a different organization about anticipatory grief in siblings. And I could probably send y'all those slides if you wanted them. But I provided an entire framework for how to have a conversation about death and dying with children of all ages. But a 4-year-old, I start with a Socratic question and I let them kind of lead the conversation. Do you know what's wrong? Do you know why your baby's in the hospital? Why is your baby in the hospital? And see what they say. And then just take every answer that they give and lead them to where they're going. So I'll give you a 4-year-old real life example in the NICU. The family needed my help explaining the diagnosis, the prognosis, and like the death and dying experience, all of it with their little 4-year-old girl. And I asked her, she was real smart, real precocious, why is your baby in the hospital? Oh, my baby's sick. Okay, what part of your baby is sick? His lungs. And I'm like, okay, that's a great starting point. You can do a lot with that. And just kind of taking that where it goes, saying, okay, that's right. His lungs are sick. They can't work by themselves. So what's helping your baby's lungs work? And we talked about the ventilator and all of the machines and equipment. And we eventually got to, okay, well, the ventilator is the only thing making your baby's lungs work, and your baby's lungs cannot work without it. What would happen if that machine turned off? Yeah. Okay, well, what is that? Well, the lungs would stop working. What does that mean? He would stop breathing. Okay, what does that mean? Well, that means he would die. And kids will get there. Especially a 4-year-old, they might have already had a death in the family. You can use any prior deaths to draw some similarities. Kids, this is going to sound really silly, but 4-year-olds have seen bugs die. They know kind of what that's like. So using something concrete and simple, real concrete language works with kids. You can't use euphemisms like they've passed on or they're going to the great sleep or, they're sleeping or they're at peace or God took them. Those things don't make sense to kids. They just don't. You have to say die, death. It has to be permanent. You have to explain what that means. I can give more examples. I could go on for an entire hour and a half about this topic, but there's a great book out there called I Miss You. Again, I'm not affiliated with this company. I Miss You. It's, I think it's an Elf Help book or a First Look book. Can't remember which one. It is a storybook, and kids really do well with stories. So using any kind of storybook really helps kids process. And in the back of that book is actually some tips and tricks for parents. But I give that to preschool age kids, young school age kids. And then a lot of it is equipping the family with knowing what to expect and what's normal. Kids grieve differently than adults. So letting them know that it's normal for them to not cry. It's normal for them to, go play and act like nothing's changed. And then all of a sudden, throughout the day, when you least expect it, they're going to say, my baby died. My baby's dead. My baby's not here. My baby's not coming back. And that's really shaking for families. It's disturbing when in public at the grocery store, your 4-year-old says that. So just prepare them for experiences like that and how to handle those things and kind of some things to look for if you're worried that maybe they're not coping well or don't have the skills to cope with their grief, like prolonged sleep disturbance, prolonged night terrors, things like that. So there are some resources out there. What Will I Tell the Children is a beautiful resource, takes you through every developmental age, has some great practical tips. I think it's through Nebraska Medicine. Again, not affiliated, but we use it all the time.
Those are great suggestions. Gosh, I'm trying to like scan through all these great questions. You guys are doing amazing. We'll just keep going as long as Taryn can. Oh gosh. So I've recently been told that silence is violence. Is this true?
I would say, tell me more. What is that? What do you mean by that? Silence is violent.
I've heard this in maybe like in crucial conversation context, but not really in grief.
I guess it would depend on the person. I could imagine a situation where if there's a not healthy, like if there's a distrusting relationship between the provider and the family per se, or maybe someone has already not been compassionate toward the family and they're silent, how that would be perceived by the family. I could see that being, I guess, violent in a way.
Yeah.
So I think that's really where reading cues comes in, like they're going to let you know if they're done or they're going to let you know if they want more. And it's really how you integrate that silence, giving families enough time after you ask them a question to think, I think is more of what I'm trying to say. When they're telling their story, giving family enough time in between pauses where they're linking their stories together to keep going and being attentive and silent in those moments. And then a lot of times, I'll tell you a time when silence was not violent. I was at the bedside with a mom when her daughter was dying. For 2 hours, I stood with her while her daughter was dying. And I said absolutely nothing. There was nothing I could say as her daughter was dying that was going to make anything any better, but I knew there was a lot that I could say that could make it worse. And I didn't want to disrupt their experience. So I just stood there silently the entire time. And I followed up with her after her child died, after she left. And one of the first things she said to me is, "You stayed."
Wow.
You didn't leave. You stayed. You didn't have to say a word, and I knew you were there. And that, to me, spoke more loudly than anything I've ever said to anyone, is just showing up.
Mm-hmm. I think that's really valuable to think about, is that we can't make it better, but we could make it worse.
That's true.
I think that that's a really helpful thing to remember, is just silence and being there.
Yeah.
It's really profound. Switching gears a little, people are asking, one person said after they take home an event or they've cared for a baby who's died, and it's hard on them that they watch a funny movie or things like that. So she's saying, are there other self-care tools or ideas for supporting staff following a death? And what have you seen to be most successful and helpful?
Yes. And if this was an 1.5-hour presentation, I would have done an entire section on like staff wellness, because dealing with dying families and dying babies is so heavy and hard. It is so hard. So it's so important to take care of ourselves and know our limits and our boundaries and have some ready to go coping techniques personal to us. I can speak from myself. I do the same thing. I love to go home and watch the show Impractical Jokers. It makes me laugh. And going home to my family, I like to leave work at work as much as I can. And because of that, I actually live an hour from my hospital. So during that commute, it gives me time to listen to music or sit in silence or cry or scream, do whatever I need to do on my drive home so that I can show up for my family when I get home. And be present. And my husband's very, very supportive, and he knows what I do. So all I have to say to him is, I've had a really hard day. And he respects that. And he knows I need to go to bed early. Sleep is so important. And taking care of yourself, giving yourself permission to just go to bed. And maybe you need to take the next day off and rest or take a nap. It's really important. I'm really musical and I'm really artsy, so I love to paint. So I watercolor. I play the ukulele. I have 3 ukuleles sitting behind me in my office. So on hard days, during the day when it's hard, I'll come back and I'll learn a new chord or strum a song or sing. Music's healing. Art is healing. I would say if what you're doing right now isn't working, try to get creative and get outside your comfort zone and maybe try something new, like rock climbing or hiking or, running. If you've never played an instrument, try to learn one. Like moving your mind away from the hard thing for a minute and giving your mind a break. It helps. I've also seen a counselor. So I highly promote and recommend counseling. I feel like everyone should see a counselor, but especially people who see death a lot, counseling is so important. That's a lot to process and it can all build up and you can have moral injury and grief residue that sticks with you. So taking care of that and acknowledging your own grief. When we talk about disenfranchised grief, usually when I'm talking about disenfranchised grief, I'm talking about healthcare professionals because we all care. We are healthcare providers. So those are our patients. They're our families. We love them. We care for them. And it hurts us when someone dies or is suffering. So we are grieving too. All of those griefs, we experience it too. So taking care of ourselves is just as important.
Yeah, totally. One question somebody had, and I think this is an interesting one. So how would you correlate all of the different theories of grief that you shared with a baby who doesn't die but is born with a lifelong disability? Mm-hmm. Do you think that these same, losses occur and that these same theories could apply?
Absolutely. That's why I broke down that timeline the way I did. So the secondary losses, the ambiguous losses, all of those occur in complex and chronic illness. Always. And a kid doesn't have to die in order for there to be losses and grief. We all know that. I mean, we live that and see that, and the families live that and see that. So applying this, especially the assumptive worlds theory, is very particular to chronic complex illness. There are lots of losses that happen with that.
Yeah. This is always a rough one. What about the loss of a twin and one lives and one dies?
That's so hard. There are a couple of resources out there for this specific situation. So there's the Twinless Twins organization. They have some good resources. So at our hospital, and what I've seen other hospitals do is it's important to acknowledge that twin if the family wants to acknowledge that twin. So asking, again, making an assessment and asking questions. But if the family wants to, and most of them do, we actually have this little logo that we put up on the isolette that denotes that this is a twinless twin. And so we still refer to them as a twin. We still call them a twin. And it lets staff be alerted that, hey, like maybe this family is grieving and celebrating and it's mixed up and it's really hard. So just acknowledging that baby and that life for a family is super important. And seriously, though, this is a great opportunity for you. All of these things, you're actually going to get to see them grieve. So you are going to be there with them as they're grieving the loss of their baby. They're not going anywhere because the other baby's there. So you can support them and they can get actually more support this way than other families.
That's great. Great. So again, putting on your child life specialty hat, how do you introduce yourself and your services as child life specialist in bereavement situations? Do you have a protocol? Is there a good time?
Okay, so that's a good question. So my job description right now, I do not have a child life job description. So that's, I think, an important delineation. I'm a grief and bereavement specialist. So my child life career built up my skills to do this, but it's not my role currently. So I never call myself a child life specialist when I enter a room with a family. I introduce myself as grief support or bereavement support, grief specialist, kind of whatever the situation would call for. And then I'll kind of channel back, because I think this is actually where the question is going, is how do you bring up death and dying as a child life specialist and introduce those services? Hopefully you will have had some sort of relationship with the family, but that's not always the case, but it's definitely better if you have. I use the phrase part of my job. And that was true for all of the things I did in child life. You know, part of my job is helping kids cope with their hospitalization. Another part of my job is helping families who are grieving. And there are a lot of things that I can offer you as your baby is dying, after your baby has died. These are the things that I can offer you, and you are not required to say yes or no to any of them. I just want you to know what's available, you know, like those kind of things.
I like that. It's part of my job, or I like that wording. I think that's really helpful, probably for all of us, right?
Yeah.
No matter what your discipline is. A couple different just quickie questions around resources. So someone's asking, or maybe a comment more than a question. Someone said they read a book, Waiting for Gabriel, recently. It was a story of a loss from a mom's perspective. She's recommending that. So I don't know if that's something that
I'm going to write it down.
Another is, you must have mentioned, you've mentioned several websites, so I'm not exactly sure when this was, but it said the name of a website for support after death.
Okay, there's a bunch. My favorite is whatsyourgrief.com. And I've linked, on the paraphrased glossary, and also let me say, those are my words and I paraphrased things, so I didn't cite anything on the glossary, but the website that I've written there is that What's Your Grief website. If you type anything in their search bar, I guarantee you will find something. They have webinars, they've got brochures and resources and blog posts, and it's just very robust.
Great. How soon after discharge should someone follow up with families? Is there a standard that works well?
Yeah, so I did an evidence-based practice review at my hospital, and I reviewed all the literature about bereavement follow-up support in pediatrics. And what I discovered is that there are some themes and some consistencies, but it has to be personalized to every family. So how soon question is, give them resources as they're leaving. Give them a specific phone number they can reach out to if they need anything before you call them. And then I would call them at the 48-hour-ish mark, so 2 days after, just to make sure that all of their funeral home planning and the morgue transition and all of those very logistical things family have no idea how to navigate, that you can support them in that. And then after that, what we do is we start heavy and we taper off. So we call for up to a year after the death. And that was really consistent in the literature, is families need help navigating through all of those big milestones that first year. So I do a 1 month call, a 3 month call, a 6 month call, and a 1 year call. And then I also send out grief support mail in the interim. And we have condolence cards that staff will write notes in. We also do a birthday card, the first birthday after the death, as we're remembering your child on their birthday. And then an anniversary card that goes out that 1 year mark.
That's awesome. I think just having that standard, I like that. Oh, goodness. I think we're down to a few more. Do you have it in you, Taryn, to keep going?
Sure.
Maybe this is an easy one. Do you see a place for palliative and bereavement support in all levels of NICUs?
So our hospital has all levels of NICUs. Most of our consults have been in level 4, so the most acute, the most sick. We've actually never had a consult in our well baby nursery, which makes sense. The question you should ask yourself is this baby going to have complex medical conditions, or is this family in crisis more than others, I would say? Or does this baby have a life-limiting illness? like a shortened life expectancy or a lot of complex medical decisions happening in their future? If the answer is yes, you can put in a palliative care consult. The palliative care teams that I know of, and ours as well, what we do is we pre-screen. So we just kind of have a discussion and see if this patient is actually appropriate and what the needs are. And then the palliative care team is able to say, these are actually things I can help with, or actually let me equip you with some skills and you can go do this. So it never hurts to put in a consult. And trust me, we're so busy that we'll only take the ones that really need us.
Yeah. This question's an interesting one. So do you think opportunities exist where NICU parents could be educated about grief? What could or would that look like? And I'm wondering if they're maybe talking more about that anticipatory grief, like those and I loved how you talked about, just acknowledging some of those losses that, many parents feel.
Yeah. Oh, it's a hard one.
Any other comments on that?
I do think it's important that we're all kind of validating and educating on grief. I mean, that's coming from me as a grief and bereavement specialist. That's my perspective always. But yeah, just like those little moments where you hear specific comments to say, can I share something with you? I just want to validate your experience, and then do a little education on, like, that's grief. You're grieving. This is your loss and this is your grief, and it's okay. You're normal. And I'm here for you. And like, more formally, I'm not sure because typically hospitals don't want to talk about dying. So it would be probably pretty hard to do some formal education within a hospital, but there are definitely community organizations that do a lot of education on grief and bereavement.
Yeah. There's somebody saying that they're at a hospital that doesn't have inborns. And they're wondering, how to connect with maybe some more, I'm guessing what I'm reading between the lines is, maybe having psychiatric and psychosocial services that are maybe more maternity oriented.
Yeah.
How can people navigate that if they feel like, they're in maybe just a freestanding children's hospital versus a birth center?
Yeah. So I guess to that, I would say if you're working in a NICU, you need to be minimally educated on maternal mental health, no matter your discipline. So that's just a self-education. If your hospital doesn't provide it, it's just good practice, in my opinion. But I think another thing that you could actually do is partner up with the women's hospitals that feed into your NICU and ask them what services they provide their patients. And all social workers are trained in mental health screens. Some social workers can actually provide mental health support, LCSWs. But it's important for us to at least know in our community what's available and how we can be helpful.
That's great. No, I like that idea of just reaching out to your network and getting that. All right, one final, and it's kind of looping back to staff and supporting staff. Everyone is just saying thank you so much.
You're welcome. Thank you.
And just those of you who are hanging on, you're amazing. And they're like, oh, more questions. Okay, so how about, I think the anger thing that when we talked about anger, that really resonated with people, and they were saying, how do you build resiliency and how do you build capacity for your team to be open and help that? What are the staff, kind of generalized staff training programs that are out there? Or, I'm just thinking, like, do you do a debrief, or, can you role play that to build resiliency?
For sure. So I'm actually simulation trained as well. And we have a whole sim center here where we do like breaking bad news and all sorts of stuff. So yes, you can role play it. And that's a really great idea to do. System support for that. Debriefings are extremely important for teams. Like team debriefs, but even one-on-one debriefs, with maybe a fellow colleague that you trust, and just being vulnerable and honest. That takes some effort on your own side, but saying like, hey, I need to talk to someone. Can we have a 5-minute break or a 15-minute break? Talking to your manager is always a good thing, because your manager actually has some control over if you need to go home or take the next day off, and they can support you in that. And then at our hospital, we have something called the Tandem Support Team, and I know that's a national organization. It's like Tandem. There's a training for it for mental health professionals that you can call, and you can actually start this in your own facility, a Tandem team. But it's people who are on call, other healthcare professionals who are on call and currently working and are available to come do one-on-one or group listening and debriefing.
Interesting.
Really great resource. For me personally, like away from the system side and programs, took a lot of crying and a lot of like building up to it and just desensitization in a way. I hate to say it. It's just true. It's the reality. And learning how to stay. So I would highly recommend Brene Brown's book, Braving the Wilderness. That book taught me so much about learning how to lean in to difficult situations instead of pull away. And she gives some really great skills and tips. So, and it's a quick read. All of her stuff's great.
That's good. So one last one, but probably a really important one too. So this person says, if you're a NICU nurse and a grieving mom, how do you help families? And do you share your story, and how do you maybe navigate that? What would be a suggestion?
Oh man, that is so hard. I have a very tender place in my heart for healthcare professionals who've lost their own children. There's clearly a compassion there that's a different level, right? So you can actually empathize with people. And that in and of itself is a silver lining and a strength that you have grown to be able to work with families who are grieving while you're grieving yourself. It's very difficult. I think the most important thing is to know your own boundaries, to have a really honest self-conversation and know what you can handle and what you can't, and giving yourself permission to step away when it's too much. Taking care of yourself is going to also take care of that family you're serving. So I have had some bereaved coworkers share some things that they have said and done in these kind of moments. My advice, take it or leave it, would be to not offer that up. Not like offer your story up without the family asking. 'Cause sometimes families will ask, like, do you have children, or have you ever experienced this before? Sometimes they'll ask when they really trust you. And if they ask, I don't see any harm in you being honest, but keeping it brief and enough, just enough so that they know that you care deeply and that you do on a level understand their pain. But if they don't ask and without prompting, I would keep it to yourself and just use it as fuel to just do the best right by them and care for them the way that either you wish you had been cared for, or, you know, the way that you were cared for, that you loved. But use it as fuel and only really share when the family is asking for it.
Super. Great. I mean, such great, thoughtful answers to the questions, Taryn. Thank you so much again for everything. I think we finally have answered them all. Thank you, Kathy, for feeding them into her. For those of you that are left, all 117 of you, thank you. I'm sure you want to know how to receive your free CE at this point. In order to get that, you need to fill out the webinar evaluation. In the chat area, we are going to post a link to the evaluation. If you're watching the recording, please go back to the email you received with the link to the recording and click on the link to the evaluation form. You will receive an email with a PDF of your CE certificate within 24 hours after you fill out the evaluation. Be sure you check your spam, as always, if you don't receive it, just to make sure that it didn't end up there. If you are watching live and don't have time to fill out the evaluation right now, or your hospital has blocked access, you will receive that same email within a day or so with a link to the evaluation as well as a link to the recording. And just one quick thing, if you are watching as a group, which many people I know watch as a group, you each need to fill out the evaluation in order to get the CE. So, and it would mean a lot to us if you liked us on Facebook and LinkedIn. You'll be the first to find out about what's new at Dandelion, but we also offer many other resources like the ones that Taryn just gave. We almost never post about products or anything like that. We really try to look for interesting stories and other things that might be relevant to your work in the perinatal areas of the hospital. We're not quite sure when our next webinar is yet, so stay tuned or look on our Facebook page. But again, thank you all for watching and for listening, and so many thanks to Taryn for just a brilliant webinar and so much wonderful information.
Thank you for having me.
Thanks, Taryn. Thanks, Kathy Randall.
Thank you, Taryn. Yeah.